Good afternoon and welcome everyone. I'm here to present my 3-month progress report of my PhD studies, which is investigating sports injuries with a focus on anterior cruciate ligament and its correlation to development of knee osteoarthritis. I'm Robert De Jonge from Uzsoki Street Hospital, Department of Orthopedics and Traumatology. To understand my vision, it's important to know that the anterior cruciate ligament is one of the most studied topics in orthopedics. But despite this, there are still a lot of gaps and disagreements. So my vision is to understand the nature of sports injuries, provide a better healthcare and life quality for knee-injured patients. And we could achieve this by resolving disagreements and controversies of anterior cruciate ligament injury. Therefore, we have started 2 projects. First one is comparing conservative and operative treatment of anterior cruciate ligament tears. And the second one is adding an extra procedure to further develop the technique of surgical reconstruction. And both of them are a meta-analysis. My first topic is reconstructive treatment versus conservative. As a background, there are more than 2,000 anterior cruciate ligament ruptures a year in the US, of which more than 130,000 are reconstructed. ACL rupture leads to instability, which is a strong risk factor of early onset osteoarthritis. In numbers, that means up to 50% of ACL injured patients are affected with symptomatic osteoarthritis, and up to 90% of patients develop radiological signs of osteoarthritis. The treatment is basically the surgical reconstruction, which is the gold standard, and the conservative treatment is an alternative. So all in all, yes, operative treatment is more common due to its associated improvement in knee stability and restoration of activity. However, with a good rehabilitative treatment, dynamic stability could be effectively regained by muscle function, as well as it eliminates surgical complications. So all in all, until today, we still don't understand which option could be better to prevent the osteoarthritis of the knee. Therefore, our goal is to find the best possible practice to prevent early onset osteoarthritis of the injured knee. Our clinical question is, does ACL reconstruction decrease the radiological signs of osteoarthritis and has a better functional outcome compared to conservative treatment? We are investigating isolated ACL ruptured patients who are attending ACL reconstruction compared to conservatively treated ones, focusing on radiological and functional signs. And our hypothesis is that reconstruction has a better outcome compared to conservative treatment. And how we can implicate this for practice? We are trying to help decision making for surgeons with our results, and with the help of this, individualized treatment could be carried out. So we could reach better outcomes for our patients and prevent post-traumatic osteoarthritis of the knee. Therefore, in the long term, we could provide better life quality for the patients. We have done the systematic search in the 3 big databases with our search key presented here. We had more than 13,000 records, of which 86 was selected for full text screening. With my co-author, we have done the full text screening, and right now we are discussing our disagreements for the final plot, and as well we have started developing our data extraction table. That's all for the first topic, and the second topic, as I mentioned, it's about further developing the operative treatment. As I said, ACL injury is the most common knee injuries, and the gold standard treatment is reconstruction with a good to excellent outcomes. However, 25% of the patients experience residual rotatory instability of the reconstructed knee, which leads to poorer outcomes. And this extra procedure, the lateral extra-articular tenodesis, which uses a part of the iliotibial band of the patient guided through the tunnel which was drilled for the ACL graft, is considered as an additional process to reduce the rotatory laxity of the reconstructed knee. And our aim is to find out if ACL reconstruction with LET is superior to reconstruction alone. And that's our clinical question as well. We are investigating patients attending ACL reconstruction plus LET, compare them to reconstruction alone, focusing on knee stability, functional outcomes, and graft failure. Our hypothesis is that ACL reconstruction with LET decreases rotatory instability and leads to better outcomes compared to ACL reconstruction alone. And how we can use that in the practice? We are about to improve knee stability, and if we can prove that with our study that it can be improved with the lateral extra-articular tenodesis, then we could shorten the time to return to activity of the patients, as well as improve graft survival, which lowers the rate of revision surgeries, and we could prevent early onset post-traumatic osteoarthritis. Therefore, it would offer a better life quality for the patients. We have done the systematic search with our search key, and we found more than 2,600 records. We have done the automatic duplicate removal, and the manual is in process right now. So this is my two topics. Planned submission is May 2020 and August 2024, the second topic. Thank you for your attention, and I'm pleased to ask, please feel free to ask questions. And my motto is that only time I set the bar low is for limbo. Thank you for your attention.
I wanted to ask if are ligament injured patients more prone to osteoarthritis?
Yes.
Why is that?
As I said, ACL ruptured patients have a chance up to 50% to develop symptomatic osteoarthritis, which is a 10 times higher rate than the general population.
I would like to ask you to go to the clinical question, please.
Of which topic?
First topic. In this matter, you will check the radiological signs of osteoarthritis.
Yes.
Is in the outcome in function because radiological signs is just one part of the function, or the function is most important.
Yes, that's why we have the outcome, the radiological signs. We are investigating with that with the Kagran-Lowrance scale, which we can calculate that from the X-ray image, and there are functional outcomes we are investigating, which is an objective and subjective forms used.
Thank you very much.
Hello, and just wondering that when is it an option to do an ACL reconstruction? I mean, the population, you have to decide that treat it conservatively or with reconstruction. Doesn't it affect the outcome of the meta-analysis? Because the population might be not the same for the two interventions.
Yeah, that's totally right. In interventional studies, it's really hard to do the blinding because we expect that surgery has a better outcome. That could be a bit of a hard point, but we will deal it.
So, as you answered, I think it's something you have to discuss with your supervisors and with the team you're working on it, because I think it's an important question to be answered before the meta-analysis is carried out.
Thank you for your remark.
Thank you.
Can we go to your first selection slide? So we are at this stage.
Yes.
And that could be important for the others too. So now you are at 6 to 10.
Yes.
So what does it mean 6 to 10? Why 6 to 10? Why is just not that straightforward? Are these all RCTs?
No.
And what are the dilemmas?
No. There are a few studies that was included in the selection by my co-investigator, and there are some that I have included and not those that Miklós had. So we are discussing that if those could fit our investigation or not. That's why. So it's.
But this is what I'm asking. That what kind of questions you have? I mean, that one says that this is okay, the other one says this is not okay. I mean, just for all the people who sit here, I mean, understand that what kind of difficulties could be seen.
Basically, that like Balázs asked that the population of those studies is because reconstruction is basically for young and more active patients, and conservative treatment is for older, less active patients. So there could be a discrepancy in the populations. That's why what we are discussing right now.
Congratulations on your nice presentation.
Thank you.
Since you've already in the full text selection phase, have you encountered any differences in the follow-up time for these patients? Is this important? Is this highly variable among the studies that you're planning to include, and will this influence your conclusions, basically?
Yes, there are differences in every studies, but we hope that we will have enough data to have good conclusions.